Now, for the next presentation, I would like to call upon the stage Dr. Manisha Singh ma'am, and she is a professor in the Department of Surgery at Raja Government College, Medical College. She is also a consultant diabetic limb salvage surgeon at Gwalior Diabetic and Food Care Center, Gwalior. Ma'am, please.
Thank you for the invite, Chairperson sir. And I thank the organizers Pallavi and Ashutosh for having me here in the city of Lord Shiva, who is the god of surgery. So I really thank and the members organizing team and Pratima and Vishu for streamlining the things for me. So I shall be talking on a different topic like clinical approach to new DFU and choice of antibiotics for diabetic foot infections included in that. Basically I'll be speaking on how we approach a new diabetic foot ulcer. So it's mostly the physicians who send the patients to us, and because they examine the patient and look at the feet of the patient and send it to the surgeon. But in our country where the podiatry infrastructure is not well developed, or the foot care is not a different science, it's mostly examined in an overcrowded OPD in a primary healthcare center, where the basic examination of blood sugar as well as basic foot examination may be missed. Especially these urban centers have few upcoming diabetic foot targeted clinics or multidisciplinary clinics, but the rural areas it's still lagging behind. And the, yeah. Sorry, display is not there. So as I said, in the primary health care centers, the basic foot examination, the basic diabetes examination may be missed. In the rural settings, we have few urban foot care centers or multidisciplinary foot care services. And the hallmark of diabetic foot infection due to several socio-cultural and religious practices and habit of barefoot walking, application of diabetic foot ulcer with all the home remedies, and you can see the dirty maggots or the ants. They are crawling out of the soil dressings which they are not changing. So all these, the hallmark is the infection in these wounds. And we know more than 50% of the diabetic foot ulcers which we see may be infected to certain extent when we see them first. And 17 to 20% of them only, that is only 1/6 or 1/7 would need an amputation. So presence of peripheral arterial disease and neuropathy, they add to the complexity, risk of infection, make the wound slow to heal, and increased chances of hospitalization, increased chances of amputation, poor quality of life, and high economic cost. So increased mortality as well. This makes it a very, very compelling case of early recognition and prompt treatment initiation for especially the ulcer which I've seen for the first time. So we can see that the antibiotics and the diabetic foot infections, the antibiotics, the earlier they are started, and it is at this stage that we can, if the patient is seen in this stage, and the antibiotics may be able to reverse, or even minor surgical procedures may be required. Otherwise, they lead to the catastrophe or disaster of amputation and increased mortality. So the thing is that it's a challenging situation and requires immediate multidisciplinary or collaborative assessment within 24 hours to prevent the infection. So once the foot reaches the multidisciplinary foot services, So that takes 24 hours to reach, and within 24 hours of reaching the multidisciplinary or the foot care center or the endocrine center or the diabetic foot center, they should be seen first by any resident or any healthcare professional in the within 24 hours if you want to prevent the catastrophe. So the when to refer urgently should be known to the primary healthcare practitioner, such as signs of deep infection in the foot or the ulcer worsening, foul smelling, there is abscess or spread of infection, cellulitis, and the wound is worsening, there are blisters, deeper ulcer which are exposed and tendon and bone can be seen, or there is a bleached, pale limb which is having no pulses, almost lifeless, or there is blackening. All those cases they have to be referred, and initial assessment and evaluation should include not only the history and physical examination, isolation of the or triage of the patient, wound characterization, imaging should also be done as fast as possible to reach a provisional diagnosis. And the wound care and debridement in the core management strategy, sending cultures from the deep tissue specimen, and deep tissue decompression by providing offloading to the ulcer and alleviating pressure or the pressure underneath the ulcer so that it's allowed to heal. So providing for a offloading, and then evaluation of vascularity of the pedal pulses stand first. If you feel that there is something wrong with the pulses, you can go for advanced vascular imaging, AB index, and the radio imaging. Rehabilitation and risk management must be started that early, and wound dressing principles of either donating moisture to the dressing or absorbing moisture from the wound should be kept in mind. So it is also examined, if you know what your brain knows, you can see that the plantar presence of plantar fissures. Sometimes I have seen patients with extensive plantar fissures and having deficient posterior tibial artery pulses or sluggish monophasic flow. So you should be able to look at the dorsal calyces on the hammer toes, overriding or crossing or the crowding of the toes, previous ulcer scar, which is a potential scar for developing an ulcer, intertrigo or fungal infection in the web spaces, crowded toes, blisters, sudden onset purplish blisters, which may be again ulcer site, onychomycosis or the fungal infections, abundant callus at multiple points, and we should be screening this patient with at-risk foot. These are the at-risk conditions. So this is dependent upon the risk stratification which is done, and they should be instructed not to walk barefoot even inside the houses. So the clinical care process of the new diabetic foot ulcer, which we have to conduct in this way, and the another is the structure of the integrated care process when the ulcer is seen first, that is decides not only the risk stratification but also the various it clears up the referral pathways and the patient reaches the destination to the foot care services. So this can also prevent the further amputation. So as we said that we have to inquire not only into the history of the causation of the ulcer, but also if there were any previous scars or previous ulceration, prior angioplasty, any revascularization procedure if it was done in history of smoking, and so on and so forth. So examination for the vascular assessment, we have to first start with the pedal pulses examination. You have heard about the color of the limb, and perform Burgess test if necessary. So the pale foot shows poor perfusion, dusky dark red foot, or the classic sunset foot, or severely ischemic black foot. So and assess when you look at the pulse, you should not only feel the pulse but also see that it's diminished or absent or it's present, compare it bilaterally on the same pulse, and note the temperature and capillary refill along with the pulses. So here itself when you are palpating, there is a clue that if the weak or the absent femoral is there, but the it's plus minus femoral and distal you have no pulses, it means there is a more proximal or the aorta-iliac femoral disease. And when the femoral and popliteal pulses are present but there are absent foot pulses or leg pulses, it means it's a tibio-peroneal disease, which is the commonest presentation seen in the diabetics. So tibial disease is more challenging because of the small vessel size. So pulse itself gives you a lot of information. Several other non-invasive bedside tests like ABI is available, and other Doppler ultrasound or the segmental pressure changes and the advanced imaging if needed. So the most important is that you have to examine as a whole also, and general assessment should not be missed. History of claudication, rest pain should also be noted, and should be distinguished from neuropathic, which is more of burning, tingling and constant, compared to vascular, which is more of exertional cramps, coldness or continuous rest pain in the instep of the foot. So the pressure studies, ABI is only helpful nowadays to rule out a vascular problem, and artery walls are often calcified in the diabetics. So falsely elevated ABI due to median sclerosis, arteriosclerosis may be there. So despite significant PAD, you may get a higher ABI. So only the waveform is actually reliable if you take a tracing, and triphasic waveform shows just normal arterial flow, biphasic mild to moderate disease, and waveform is more reliable than ABI in diabetic patients. Toe pressures or the TBI is again more important. Toe pressure less than 30 indicates ischemia. Less than TBI 0.65 or more is normal TBI or the toe brachial index. So again, segmental pressure test studies, they are done but more cumbersome, and TCPO2, it's not available in all centers, especially it's present at centers where HbO2 is there, and if the TCPO2, if it's less than 30, it signifies risk of non-healing of the ulcer. So if the patient asks, will the ulcer heal or will it get amputated, this TCPO2 will tell. If it is less than 30, less chances of healing are there. So CLI, as we know, is again enough supply is not there to perfuse the tissues. So when the CLI is there, which means there is ulceration, gangrene as well as the rest pain, then the chances of healing is less, and you need advanced imaging, and revascularization has to be planned. So to indicate that there is an amputation risk or likelihood of healing, we consider Wi-Fi classification, and for the wound we can consider nowadays Sindbad classification rather than Wagner's. So you have to do complete inspection of the foot, as I said in the beginning, and the ulcers with ABI 0.7 to 0.9 are the neuroischemic, which can heal even with debridement without the need of revascularization. Ulcers with ABI 0.5 or 0.3 to 0.5 are the ischemic ulcers, which need definitely revascularization, and along with this we should not forget that it's a part of the same vascular system, so complete cardiac evaluation is a must. We should also test for neuropathy and quantify with biodosimetry, and screening methods being monofilament and the Turing fork. So sensory small fiber tests are more important than the large fiber tests, and gold standard single test for diagnosing small fiber neuropathy is punch biopsy. Then pseudoscan is also used, which is based on the sweating or absence of sweating due to autonomic dysfunction in the diabetics. So you can see all these tests, neuropad and pseudoscan are also used. These should be the primary tests rather than the monofilament or biothisiometry, because small fiber neuropathy is begins earlier. Then motor neuropathy to see the foot toes deformity, plantar pressure studies, all this should be done when a new DFU approaches. Musculoskeletal assessment, range of movement should be assessed, see any callus or any high arch foot or any rigidity in the toe movements. Then biomechanical assessment, seeing the too many toe signs, calf muscle circumference, signs of wasting, all these should be seen. And in a radio plain X-ray itself gives you a lot of information apart from others. Like you can see in a Charcot foot, you can see the loss of arch and the the bones fuse abnormally. You can see a foreign body, a pin is seen here in the plain X-ray. In a plain X-ray, osteomyelitis is seen as a candle wick appearance, or the narrowing or the periosteal reaction may be seen. Gas in the subcutaneous tissue may be seen. And you can see in the medial calcification of arteries the outline of the vessels because of the calcification of the vessel wall. So radio imaging studies, amongst them collar arterial Doppler is the commonest study performed, gives us a lot of information about the blockage if present or type of flow which is there. Apart from that, lab blood assessment, biochemistry should be done. CRP tells us about the continuous assessment. Most important is the assessment of the diabetic foot ulcer as such, seeing all its location and the various surfaces, edges, depth, size, measuring them. See the signs of infection in the form of any two cardinal signs of inflammation if present, in addition to the exudate, odor and viscosity of frank pus. So if any two signs are present, it indicates the ulcer is infected. So and you should not treat an uninfected ulcer with any antibiotics. So there is a instrument called Illuminati, which you can do with bedside illumination. You can see the gram positive and gram negative as radiofluorescence. So bedside itself you can tell. And the depth and the wound should be measured post debridement, post removal of the necrotic tissue. Then you should use the wound scale as seen in here and measure it. So you can see, apart from wound, vascular, mechanical, infection and metabolic control, patient education is also a must to offload the patient, to know when they should come for the dressings. So good granulation is seen. Microbiology, take a ulcer, take a biopsy sample from the deeper tissue once the ulcer is debrided. After that, wash with saline and then take a deep tissue sample rather than surface swab or surface cultures. So you can see the presentation as wet space infection, ischemic. So you should know that it can be seen in all these forms, and or a fluctuant abscess or a gangrene. And non-surgical offloading means providing a good footwear. The time does not permit me to go in detail, but when the ulcer is being dressed, that time also you can use a posterior slab or a casting so as to give a offloading along with dressings with a window cut for the dressing. And the various shoes are given once the ulcer is healed, and there are various toe supports for the deformed toes, which are shown in the motor neuropathy. Surgical offloading are the surgical procedures which are done inside as a permanent procedures, such as tendoachilles lengthening to remove the stiffness or to relax the fascia, to reduce the toe deformities, because the deformed toe is more liable to have all this. And patient education should be reinforced at each visit and during follow-up, and you should educate your with either the help of your multidisciplinary nurse or yourself or any other aid you have kept with the physiotherapist. So apart from the in the neuropathic and neuroischemic DFU, we have to see if the ulcer has no infection, then we do a sharp debridement, wound care, or the minor debridement with TCC offloading. With cellulitis or soft tissue infection, you have to do a gold standard sharp debridement more extensively under anesthesia instead of bedside debridement, provide offloading. With osteomyelitis, then you have to remove the bone culture has to be sent, or amputation may be needed. Ischemia, you have to consider for revascularization. And so healing as predicted should be less than 100 days or even 4 to 6 weeks in a neuropathic or a neuroischemic ulcer. More than that, you should think of a vascular issue and you should go for revascularization procedures if necessary, or add some drugs like rivaroxaban or cilostazol for improving the blood flow. Plus there are other dressings which improve the blood flow which can be provided. So the time does not permit, and I said that it's the contamination count when it goes microbial load is more than 10.5 organism per gram of tissue. There are presence of infective organism, diversity of microbes, and synergistic association of microbial species. Then the ulcer is going to form and it's going to multiply the pathogenic organisms within the body tissue and they create a ulcer. So you know that when you look at this, that MRSA prevalence in India is very high, and risk factors for MRSA may be the prolonged hospitalization, repeated antibiotic use, or severe DFSI. So start the empiric anti-MRSA therapy and anti-pseudomonal therapy only when it is showing in the culture reports. So anaerobes should be targeted in deeper wounds. Similarly, multi-drug resistant bacteria will be present in the deeper wounds. If the wound depth is more than 3 to 5 mm, you should think of anaerobes, particularly in a tropical country like ours. And triopathy of the foot makes the foot vulnerable, like poor foot edema, poor immune response, along with neuropathy and the peripheral arterial disease. So peripheral arterial disease may be seen more than you can imagine. 50 to 78% of the DFU will have peripheral arterial disease, which makes it a very complex situation to heal. And apart from that, there is endothelial and microcirculatory dysfunction. So necrotic tissue with biofilm is there. So diabetic wounds are stalled in this process, and there is excess inflammatory response, and this leads to recalcitrance of the ulcers and delays wound healing and predisposes them to. So predominantly we should target Staph aureus and or strep initially when you see the ulcer, and later you should send for the targeted antitherapy, and aggressive debridement is needed with possible adjunct therapies and newer agents. So you have to scale down to targeted therapy is very important, because these patients may be otherwise become drug resistant. So once you have done that wound bed preparation, you should actively examine it again and again at each dressing is important. And surgical debridement is the most superior way of debriding compared to the autolysis or the enzymatic or the hydrosurgical debridement. And timely and aggressive radical wound debridement is essential, should not fear, and it should be done by experienced surgeon, not left to any junior member or a nurse or wound care nurse. It should be done properly with full aseptic precautions. So do not culture uninfected wounds, IWGDF guidelines. Culture results guide targeted antibiotic therapy, avoid taking surface swab, bone biopsy of exposed bone is taken to diagnose osteomyelitis. Deep tissue cultures are more representatives. And we know, being physicians, there are so many physicians here, I can't, क्या कहते हैं, विद्वान व्यक्ति को दिया दिखाने की ज़रूरत नहीं है. So common antibiotics you are prescribing day in and out, and newly approved antibiotics have come up out. Yeah. We are less cerebral, more mechanical. Oh, okay. So we have already spoken of empiric and culture directed and guidelines as per IWGDF. Dosage schedule should be in extensive infections, slow resolutions. We should give 3 to 4 weeks of antibiotic therapy. And if it is not resolving in 4 weeks, then we have to again do a targeted culture study. And if the bone is projecting out or the bone is there inside, you have done a minor amputation, bone is inside infected bone, we should give it for up to a period of 4 to 6 months also the antibiotics. Combination therapy should be preserved. Local antibiotics have a less definite role, and there is failure to show more evidence is not there regarding them. So clindamycin is fine for mild disease only, and ceftaroline and tedizolid are being more and more used for MRSA, telafloxacin. So you should think of gram-negative coverage and anaerobic coverage in our conditions. Good glycemic control is the backbone of the entire healing, and it is HbA1c is also a predictor, and 1% of wound healing. So choice of wound dressing, ideal wound dressing should be, there's no one ideal dressing because it's a heterogeneous pathogenic entity, diabetic foot infection. So no one dressing is the ideal one, but we should remember the don'ts. We should not use harsh solutions like hydrogen peroxide, Savlon, betadine, which are cytotoxic directly on the wounds, and do not cross the even biofilm barrier. So normal saline still stays the best cleansing solution and should be tried often. It's non-toxic. Something that you can instill in the eye should be instilled on the wounds. These wounds are very delicate. So I will now move on to, there are several things, various types, and I will not, you can see the chronic Charcot with glass piece injury healed completely. I'm coming to the last slides. Adjunctive procedures like NPWT, negative pressure wound therapy, VAC therapy, which are in vogue, and they cause lot of excitement when the people see them, and they are very effective, but they are not the monotherapy. They are just the adjuncts to the wound healing and should not be used as. So choice selection or the case selection must be there. PRP is another one. Topical O2, O3, very effective in the ischemic wounds. And revascularization cases also do not translate to the wound, so you can use topical adjunct of topical O2, O3, HbO2. So there are many things which can be done. I come to the last slides, that at-risk feet must be prioritized to receive foot protection and education, footwear, and they should be given reinforced diabetic foot education at each visit. And a DFU must be referred to multidisciplinary foot services within 24 hours. Regular audit and reassessment of pathway for right foot care must be carried. And antibiotic therapy is just one piece of a puzzle. The trend that clinicians are increasingly tasked with using potent newer antibiotics which offer expanded options, and they should not be use them recklessly because it will lead to lot of antibiotic resistance. Antibiotic stewardship is very, very important. Multidisciplinary approach, it makes the it reduces the amputation. It may prevent amputation by 49 to 85%. So collaborative or integrative approach is it is the useful adjunct. And practice preventive foot care to propagate on diabetic limbs for a lifetime. Foot is a masterpiece of art and engineering, and so you have to tread on it for a lifetime. So take care. Thank you.
थैंक यू डॉक्टर साहब. एनी क्वेरी? आप जो बताए हैं इससे ज़्यादा हम लोग करते हैं डॉक्टर मिश्रा के हॉस्पिटल में. और इसके साथ हम लोग
But sir, my work was to for the all the physicians.
ये जितना आपने किया बताया ये सब तो करते ही हैं, साथ में हम लोग वासोडाइलेटर, पेंटॉक्सीफाइलिन या
I mentioned them.
कंप्लामिना ये सब हम लोग उसके साथ विथ स्टेटिन और वो
उतना ही आया है सर, मार्केट में भी उतना ही आया है जितना आप कर रहे हैं.
वो सब भी कॉम्बिनेशन में देते हैं रिकवरी में, उसके बड़ा रोल है ना.
सर लेकिन अगर हम इफ़ यू केयर फॉर इट, इफ़ यू आर आफ्टर अ फुट इट विल हील, दैट्स माय एक्सपीरियंस. अगर हम उसको ढंग से वो करते हैं. और एक चीज़ ज़रूर कहना चाहूँगी, लॉट ऑफ डर्मल एजेंट्स, मैट्रीडर्म एंड ऑल दोज थिंग्स हैव कम अप. नॉट ऑल फुट रिक्वायर्ड दैट. They are very extensive things, and they may be needed in certain situations if the patient is affording, then that can be done. So I have used Matriderm and the dermal adjuncts, especially they give a good scar and all that, but for select cases.
लेकिन एम्पुटेशन के लिए तो बहुत जरूरी है डॉक्टर साहब. यदि यू आर अवॉइड द एम्पुटेशन.
Yeah. So there are indications, sir. Topical esmolol, these are for mild ulcers. I have used them extensively, and topical esmolol gives good thing. Only one side effect, it may give blackening at the site, very few cases. So it does help, but once the wound is granulated, after that it helps. They usually say that in a dry wound, if you put, it doesn't help. It helps more after some granulation has come up, infection is cleared up, post debridement it can be used.
The thing is, any diabetic, there is first thing is to classify whether we are dealing with a dry wound or a wet wound. Main thing is that infective or non-infective. Suppose your wound is a dry wound, and in that case, hydrogel and other agents which are providing moisture to the wound is very, very important. Another important point is if you are dealing with a patient who is wound is more ischemic type and it is a wet kind of wound, then in that calcium alginate kind of thing can be given, which will absorb the moisture, extra moisture which is there.
Yes,
People are now trying tropical metformin for the treatment of diabetic foot ulcer. These are also very important agent, and if you are combining the agent which are producing more nitric oxide with a tropical honey dressing with the beta 2 agonist kind of thing, that can be one of the important thing to enhance granulation. There is another kind of app which is also available.
Wound
which,
360,
yeah,
Wound 360.
Yeah, that can give you idea of whether how much is the amount of the granulation tissue, how much is the biofilm. So depending upon the situation, you can actually decide upon which agent to be used. Either you have to hydrate or you have to give the agent which will absorb the extra moisture, when to use collagen, when to use offloading in this kind of scenario.
The granulating wounds, only on that we can use a collagen.
Yeah.
एक बार granulate हो जाएगा, उसके बाद ही we can apply collagen,
that's
or we
why-
can
that's
apply
why
the
I'm-
films on
Yeah,
that.
that's why I am mentioning that.
Yeah.
thing.
Yes, sir. There has been a new product, and also earlier Placentrex was used extensively, and even this Amcoplast is being used. They used to give good result. Prior to that, in the earlier days, we used to apply the placenta, then HBsAg issues and all, they came up. So definitely they help in the angiogenesis, and the lipid component of the placenta helps in the angiogenesis. So for the same reason, in this critical limb ischemia patient, in our department, we are doing omentopexy, and that somehow the lipid component of omentum, without doing a microvascular anastomosis, if you lengthen the omentum, bring it up to the wound, it can serve a purpose. We have seen in the these ischemic wounds. We have done on peripheral vascular disease patient, we have also done on the diabetic patients. But the results are plus minus, and more cases need to be done. Well, sir, as you were pointing out hydrocolloid hydrogels, I had a slide like this. Lack of time, because the bell was, so I didn't
So that
elaborate on.
message should go to the audience that
Yes.
all wounds are not same. What I want to say that diabetic foot ulcers are a very heterogeneous kind of disease. You have to individualize the plan, and accordingly you have to treat. And some people have also tried the stem cell therapy for all
Yes,
these things.
stem cell therapy has been tried. It's expensive. Per patient, the cost comes around 1.25 lakhs. It's done at some centers, and good results may be there. It's not 100% or definite. So the patient may come around and ask, because ischemia is not the only component, there are multiple components. So it may be successful or may not, depending on even the age of the patient.
What are the ages of inducing a neoplasm after using these?
Yes, with the help of the growth factor which was available, platelet-derived growth factor, we found the incidence of this neoplasm in the patients, or the squamous cell carcinoma in the patient, or if there is a deformity being recurrent getting ulcerated, there are chances. I have seen a tumor tissue developing. Only last week I saw that, and it came out to be squamous cell carcinoma. So all those things can be done, but these are rare entities. With platelet-derived growth factors, cases have come around and they have discontinued from the market. Again, it has reappeared in the market. Even urinary bladder cancer was being reported with that, right? Apart from skin cancers and allergies. So that was there. There are 6,000 plus products available. Biological skin substitutes are available, and they are helping in the wound healing a lot. But the target is to find out all the comorbidities and all the factors which can help the healing. There is not one factor, it's multifactorial etiology and a heterogeneous entity in presentation. So you have to have lot of things.
Full thickness cadaver grafts.
Well, sir, we are using not the cadaveric grafts. They have been used, even the bovine, porcine and the cadaveric things are used. Skin banks, through skin banks also they are taking. And in the burn unit and etc. they are doing that. I am not very much aware. We are not using it in diabetes. We are using it from the thigh skin split thickness skin graft, giving good results after scoring. Even small graft can be scored or meshed and can give it in a bigger area. Or pinch graft also I have tried when the skin is less. It has helped. So the islands are formed and it regenerates. Smaller grafts also.
Nutraceuticals like Pirincetine, even GLP-1 are nowadays coming up with the diabetic foot.
Sir,
Pirincetine is one of the very important
okay.
anti-inflammatory agents which can be used in patients who are having mixed kind of diabetes.
Right, sir. So the pleiotropic action of the drugs has been exploited to, in like timolol, you said, phenytoin. All these drugs have the pleiotropic action are revisited, and these drugs are modified at a different concentration in the diabetic foot. But these are mostly targeting the already granulated, less infected mild ulcers. The action is still being studied, like Dialcus, which is used, as you said, timolol 14%. So that has been tried in that percentage, but no, it does not help in all the wounds. Especially it helps in the neuropathic wounds. Neuroischemic wounds, we cannot use them. So even I have personally done PhD in a nanocurcumin aloe vera extract and compared it with the growth factor gel, and I found that nanocurcumin dressings were excellent. We developed it from nanocurcumin tablets. We patented. We are in the process of patenting the product as well. And a polyherbal cream was also developed. So plant extracts in higher concentrations, they give you a growth factors, a lot of an anti-inflammatory effect. So that also helps in the wound healing. That is there. So already, sir, you are using a lot. It's so nice to know, and we can have a foot conference as well, where we can elaborate on smaller parts, all of which I was speaking all together. So on smaller issues we can discuss. That will be better with a target audience, right, sir? Thank you, sir.
Thank you, Dr. Sahab.
Thank you.
Thank you so much, ma'am, for the great